Bismillahirrahmanirrahim. Today we will have case quiz number 102. Case data: 47 years old white right-handed male, complaining of abrupt onset of left leg numbness while he was at work. He walked around to try to restore circulation when it suddenly became paralyzed and noticed his left arm and leg began to contract rhythmically and involuntarily. So involuntary movement and numbness with paralysis, sudden onset, with no eye deviation, face involvement, or loss of consciousness. Movement stopped at the time of arrival to the hospital, few minutes later, with no history of seizures or stroke. Past medical history was significant for migraine headaches, sinus allergy, chronic uveitis, and parathyroidectomy. He had an episode of severe uveitis at age of 8 with bilateral eye redness and soreness, and was treated with steroid and cytoxan or endoxan cyclophosphamide. His medications were oxymetazoline nasal spray for nasal congestion and daily prednisolone eye drops. He had 20 years history of tobacco use and drinks alcohol socially on occasions. No unusual exposure history and never exposed to TB and proved to be negative for TB later on. Family history of mother with breast cancer and sister with Sjogren syndrome who had uveitis as well. So his mother had breast cancer and his sister had Sjogren and uveitis. Examination: the vital signs were unremarkable. The patient was awake, alert, and following commands. Physical and neurological exam was only remarkable for decreased sensation to light touch on the left lower extremity. Investigations and initial management include CBC and the metabolic panel were all within normal levels. MRI of the brain demonstrated an intraaxial mass in the post-central gyrus measuring 2.7 by 1.5 by 2.2 centimeters. It was slightly hyperintense on T1, enhanced with gadolinium peripherally, and hypointense on flare with surrounding edema. CT scan of the chest, abdomen, and the pelvis demonstrated paraesophageal and mediastinal adenopathy with calcifications and was otherwise negative. He was started on phenytoin 100 mg TID and dexamethasone 8 mg IV 4 times daily. Given his history and the clinical findings, he was felt to most likely have metastatic disease to the brain, and resection was recommended. A craniotomy was performed with resection of the right parietal brain mass. Histological examination of the resected specimen show cerebral gray and white matter. At the gray-white matter junction, multiple non-caseating granulomas were identified. The adjacent gray and white matter showed reactive gliosis, but no evidence of neoplastic process was noted. Scattered blood vessels with perivascular lymphocytes were also present, including the leptomeninges. Each granuloma had composed of histiocyte with a peripheral rim of benign lymphocyte which were further characterized as T cell using immunohistochemistry for CD3. Because of the presence of perivascular lymphocytic cuffing, vasculitis of the CNS was considered. However, it was ruled out by the absence of fibrinoid necrosis. Another important diagnosis that needed to be ruled out was lymphoproliferative neoplasm involving the CNS. while angiocentric lymphocytic infiltrate is a common finding in lymphoma of CNS. The lymphocyte looked cytologically normal, and the flow cytometry showed no clonal lymphocytic population, so cancer is also excluded, and TB, as I said before, was excluded from the start. So, what is the diagnosis? The answer is neurosarcoidosis. Neurosarcoidosis or sarcoidosis of the CNS. Discussion of the diagnosis. Neurosarcoidosis is known as a great dilemma, great problem. It can involve any part of the nervous system during the course of its multi-system inflammatory nature, mimicking virtually all forms of neurological symptoms. It is estimated that about 5 to 15% of patients develop neurological symptoms due to neurosarcoidosis. The most common manifesting locations in the nervous system include cranial nerve, the pituitary and the hypothalamus, brainstem, and the spinal cord. Multiple or less common solitary intracranial mass lesions are seen in about 5 to 10% of neurosarcoidosis cases. The pathogenesis of sarcoidosis is non-caseating granuloma, which is similar to other granulomatous disorders such as tuberculosis, parasites, lymphoma, coccidioidomycosis, and as a matter of fact, sarcoidosis is a diagnosis of exclusion. In fact, microbiologic studies can rule out infectious etiologies. The most common systemic manifestations of sarcoidosis result from involvement of intrathoracic lymph nodes, lung, ocular, and skin lesions. Neurosarcoidosis should be kept in mind in differential diagnosis of wide variety of neurological conditions, especially when there is suggestive findings from the clinical scenario. In our case, we initially thought the nature of solitary intracranial space occupying lesion in a 47-year-old Caucasian man with brain neoplasm, most likely metastasis, glioma, or lymphoma. However, upon reviewing his past medical history, the possibility of neurosarcoidosis was very likely. Pulmonary and intrathoracic lymph node involvement can be seen in more than 90% of patients with sarcoidosis. The most common symptoms are cough and some respiratory difficulties due to interstitial lung disease, which were noted in our patient too, but was attributed to and treated as allergy symptoms. It is reported that about 23 to 26% of patients with sarcoidosis develop uveitis during its course, as in our case, and 2 to 10% of patients with uveitis had sarcoidosis. So if you see sarcoidosis, search for the eye, and if you see uveitis, search for sarcoidosis as well. Other forms of ocular involvement, such as keratoconjunctivitis sicca, very similar to Sjogren's syndrome, or even secondary cataract, have also been reported in the literature. Hypercalcemia and nephrolithiasis can complicate sarcoidosis. The incidence of hypercalcemia range from 2 to 60%, depending on the number of variables such as exposure to sunlight, genetics, dietary calcium, and skin color. Hypercalciuria occur more frequently than hypercalcemia. Although our case had a history of parathyroidectomy in the past, and his hypercalcemia and renal stone disease were attributed to his hyperparathyroidism, we didn't find any imaging documentation in his medical record suggesting that sarcoidosis might have contributed to the hypercalcemic state. Sarcoidosis is more frequently seen in African Americans, Irish, and Scandinavian descendants. Its incidence is about 3 times higher in black than white Americans. However, it can affect all races at any ages, but it is more common in African Americans. The diagnosis of sarcoidosis is usually made by biopsy in the context of clinical settings. The pathologic hallmark of sarcoidosis is non-caseating granuloma, which are mainly composed of lymphocytes, multinucleated giant cell, epithelioid, histiocytes, and fibroblasts. Other diagnostic tests such as measuring ACE level can be helpful but are less accurate. The patient's sister diagnosis is significant because sarcoidosis has been noted to cluster in families, and it is generally thought that there are inherited genetic predisposition to the disease. In addition, sarcoidosis can present with dry eye and dry mouth, ocular and aortic involvement, and can be difficult to distinguish from Sjogren's syndrome as in the sister of this patient. The patient appeared to have plump cheeks, which may have been due to a slightly stocky build. However, his parotid gland felt slightly firm, raising the question of Hereford syndrome. This is also known as uveiparotid fever and consists of uveitis, parotid enlargement, and cranial nerve pulses. It is an important differential diagnosis from our case. So, what about the key message of this case? It is possible that neurosarcoidosis can present as a solitary intracranial mass, lesion, and should be considered in the differential diagnosis, especially in constellation of other findings such as intrathoracic lymphadenopathy, uveitis, or hypercalcemia. Again, it is possible that neurosarcoidosis can present as a solitary intracranial mass lesion and should be considered in the differential diagnosis, especially in constellation of other findings such as intrathoracic lymphadenopathy, uveitis, and hypercalcemia. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 103. Wassalamu alaikum wa rahmatullahi wa barakatuh.